Hello, hi, welcome back to our latest chapter subset in this anatomy discussion. In this chapter, we'll be discussing the peripheral cannulation sites. Before we start, I would like to thank Mr. Sonal Ori, our clinical lead and lead for education, Mr. Zabi Miskolci, our adult cardiac surgery consultant, as well as Mr. Suvitish Luthra, our senior surgical fellow. In this chapter, I will not be going into details regarding the rationale, merits, and the pros and cons of various peripheral cannulation sites. This is left, we will discuss this in more details in the aortic surgery chapter. However, just in brief, in a nutshell, the fundamental concept of peripheral cannulation is trying to establish or institute cardiopulmonary bypass before opening the chest. This is quite useful in various situations, such as, for instance, in dissections or aneurysms, where you are worried upon the risks of injuring the surface of the aorta, or suspecting hemodynamic instability during the opening and institution of bypass. Also, in redo surgeries for the same reasons, where you are suspecting instability or inadvertent injury to the surface of the heart. Historically speaking, the first peripheral cannulation strategy was initially the femoral. It's still very popular, very common in a lot of centers. However, the only drawback of the femoral cannulation is you cannot establish cerebral protection because of the risk of dislodging the debris and atheroma while the blood is traveling retrograde. Although the femoral cannulation is very accessible, the femoral region anatomy is not intricate. It's easy to access and fairly least cumbersome dissection process out of the three. Next was the with the evolution of understanding these cerebral protection strategies, cerebral perfusion strategies. Hence, the axillary artery started to take the lead. With this particular strategy, you can perform cerebral protection and cerebral perfusion using one cannula without having to shift your cannula. The carotid peripheral cannulation, on the other hand, never actually substituted neither the femoral or the axillary. It is mainly, it has its own indication, its own population of use that is in the pediatric population, not in the adult population. Having said that, a lot of centers, a lot of aortic surgery centers in Japan and Asia use the carotid cannulation as a primary strategy for peripheral cannulations. We will explain why it's particularly useful in the pediatric population when we come to that. This is in brief an explanation of the, in summary, of the peripheral cannulation, and we will discuss in further details when we come to aortic surgery chapter. Let's start in a historical manner, in a chronological manner. Let's start with the femoral cannulation. First point, always we orient ourselves to the area, the femoral triangle. We all know sartorius, adductor longus. The muscle bed is the iliopsoas pectinis and adductor longus muscle. Now, if you are dissecting from superficial to deep, you will be faced with some superficial structures you need to be familiar with and oriented with. One is the junction of the saphenofemoral saphenous with the femoral vein. Next are the three superficial inguinal veins, then the two cutaneous nerves, that is the sensory nerves, that is the ilioinguinal and the femoral branch of the genitofemoral nerve. Inadvertent injury to the ilioinguinal nerve leads to hypothesia or parathesia along the inguinal region. The femoral branch of the genitofemoral nerve provides cutaneous supply to the front of the thigh and the lateral part of the thigh, the front of the thigh, leading to hyperthesia or parathesia in this region. If you dissect a little bit more deep, you find yourself in front of the femoral sheath, which is a three-compartmental sheath comprising three main structures. We all came to a point when we got a bit confused regarding the proper orientation of the structures within the femoral sheath. Don't be disappointed, that's completely natural. As we are used in this series, I will provide you with a little story to remind you with this particular detail. So, if you look here, the femoral canal is sitting in this particular point to serve a purpose. That is, the femoral vein is one of the veins of the body which is most susceptible to engorgement. Like in females, for instance, due to pregnancy, or in males due to muscular exercise, the presence of the femoral canal in this area allows a space, a buffer space for the femoral vein to engorge. The position of the femoral nerve outside the femoral sheath, again, is for a rationale. God made this to protect the femoral nerve from the continuous lifetime pulsations of the femoral artery. If they were both entrapped within the same femoral sheath along a lifetime, this will lead to neuritis due to the continuous pulsations of the femoral artery. I hope this helps you to remember the structure and orientation of structures within the femoral sheath. Now, the fundamental question, the fundamental take-home message we aim for in this series, in this chapter, is understanding where to cannulate, where and how to cannulate. In order to understand that, you need to digest and understand the, let me rewind a little bit here. You need to understand the basic branches, course, and relations of the various vascular beds. So if you look at the vascular tree in the femoral circulation, as you can see here, the femoral tree consists of the common femoral artery, and then divides into two branches, one deep, one superficial, the profunda femoris, or the deep branch, and the superficial femoral artery. The common femoral artery itself gives out the superficial inguinal branches, that is the superficial circumflex iliac, superficial externopudendal, and superficial epigastric artery. The profunda femoris gives the medial and lateral circumflex femoral arteries, as well as the perforators. The superficial femoral, on the other hand, pierces the adductor hiatus and the adductor magnus and travels behind into the popliteal fossa as the popliteal artery, which later on divides into the common peroneal and the common tibial arteries. Those are the terminal two branches. Now, where is the best point of cannulation? This is obviously the best point. Why is that? I think the diagram explains it all. If you clamp on either side and start dissecting in here and trying to establish the cannulation site, you will be punished with backflow from these branches. Also, during the course of the surgery, you will end up with a continuously bleeding site. Again, the same applies to this part. So this is the small window of opportunity you've got. You need to cannulate in this part, where applying the clamps on either side will provide you with a completely bloodless field, as you can see here. So if you apply the clamps and you're still faced with backflow or back bleeding, so probably most likely you are either too high or too low. Next is understanding a fundamental concept which applies to all peripheral cannulation strategies. So in here, as you can see, when we select the size of the cannula, we selected index to body weight. So sometimes, even though we selected it index to body weight, the caliber of the femoral artery is not big enough, and this leads to obstruction of the antegrade flow. Precluding the antegrade flow, only blood will travel this direction. The way forward from here, the way to treat this is you have two options, and this applies again, as I said, to both peripheral cannulation strategies. First option is stitching or anastomosing a tube graft, a synthetic tube graft, to the side of the artery and inserting the cannula through this tube graft. Of course, this has the problem of prolonging your surgery, also adding one more anastomosis site which may bleed. The second option, which is less cumbersome, is using a cannula with a special side way in which you can, as you can see, establish the antegrade flow through. These are the two main options you have got in those particular situations. Next is the axillary cannulation. Again, starting from the beginning, orienting ourselves to the area, the axillary region, as you can see here. The axillary region is mainly essentially a pyramid in your basically the armpit. It's a pyramid. It's a pyramid which base is the armpit region, the apex of which travels all the way up to the inlet of the chest. As you can see here, the axillary artery travels obliquely from in an oblique fashion from top to bottom. In this part, it's divided into three parts by the pectoralis minor. In this part, the axillary artery lies directly under the pectoralis major and the clavipectoral fascia, and then in this part, it lies underneath the pectoralis major, pectoralis minor. In here, only covered by the pectoralis major. In a brief area, the axillary artery is directly palpable under the skin, and this you can even feel the pulsations in there. This is very tempting. You might feel that this is very tempting for the surgeon to cannulate at. We will understand why it's not a good idea. This area is essentially caused by the fact that the lower border of the teres major travels lower than the lower border of the pectoralis major, and hence creates this deficient area where the axillary artery lies directly under the skin. Looking at this area from the side to understand more the orientation of the neurovascular bundle, as you can see here, the axillary artery lies directly behind the clavipectoral fascia. So looking at this diagram, you understand that the portal to the axillary artery at this particular point is through the clavipectoral fascia. You need to understand what structures will you be faced when you start dissecting the clavipectoral fascia. As you can see here, three structures behind give out three structures piercing the fascia. One is the thoracoacromial artery, two is the lateral pectoral nerve, three is the cephalic vein. However, dissecting from the surface, you will only be faced by two. The remaining structures will terminate their course at the undersurface of the pectoralis major. These two structures are deltoid branch of the thoracoacromial artery and the cephalic vein. Now, remember, there are four branches to the thoracoacromial artery. One, A, B, C, D. A for acromial, B for pectoral, C for clavicular, D for deltoid. Now, again, the fundamental question we need to answer during this chapter is, where is the best point of cannulation? In order to understand that, you need to understand the branches, course, and relation. Yes, happy surprise, branches, course, and relations actually do have clinical correlate. They are not just made to torture med students. As we said, the axillary artery is divided into three parts. Think about it that way. The answer is the first part, but let's see why. As you can see here, the first part gives one branch, that is the superior thoracic artery. The second part gives the two branches, that is the thoracoacromial artery and the lateral thoracic artery. Then the third part gives three branches, that is the subscapular artery, circumflex humeral artery. How convenient. First, one branch, second, two branches, third, three branches. By the way, a rhetorical question in here. We did discuss the internal mammary artery. If there is an internal mammary artery, what is then the external mammary artery? This is the external mammary artery. The lateral thoracic artery is also sometimes called the external mammary artery, simply because the mammary tissue, we mean the breast tissue in females, is supplied by the internal mammary from the medial side and the external or lateral thoracic artery from the external side or the lateral side. Hence, there is external and internal mammary arteries. Going back to our question, so where is the best point to cannulate? The answer is the first part. Why is that? First of all, there is only one branch. You can simply easily isolate that. So you will end up with a bloodless field where you can cannulate and avoid leaking throughout the course of the surgery. The second part is definitely not a good choice. First of all, it's full of branches. You will not be able to isolate the field in here, regardless of how many clamps you use, and also during the dissection process you will probably end up injuring one of those branches and ending up spending time to for hemostasis. Also, it's behind the pectoralis minor, so you will have to dissect another layer of muscle. Now the third part is very tempting. We explained how the third part lies in part of its course directly under the skin. Why is it's not an ideal choice? If you look here, this is the answer. the orientation of the brachial cords around the axillary artery brings these three cords around, overwhelm the third part of the axillary artery from all three directions, which makes it not an ideal point of cannulation. Last but not least is the carotid cannulation. Before we start, I would like to explain a point which we discussed earlier. Why is the carotid cannulation mainly used in the pediatric population rather than the adult population? So the question is, why not use the femoral or axillary in the pediatric population? Because the size of the cannula will almost always will occlude or preclude the anterior antegrade flow. The two options which we discussed earlier are not feasible in the pediatric population because the antegrade branches are actually smaller. So you will not be able to achieve a good flow, and the technique as well is cumbersome. But the question here is, if you cannulate then the carotid, is there no risk to preclude the antegrade flow? Yes, there is a risk. However, you rely on the fact or the concept of a complete circle of Willis. So the complete circle of Willis hopefully will save you during this situation. And by the way, the incomplete circle of Willis occurs, or incidentally is found in 0 to 5% of the population. So we bite the bullet, we hope for the best, and we preferably cannulate through that pathway, through that carotid strategy. Also, the carotid cannulation is not the ideal strategy in adults because of the risk of atheroma and the atheromatous burden and debris, so you risk inducing stroke. However, in the pediatric population, this is not a valid risk. We mainly use the carotid cannulation in the pediatric, in most centers, in establishing ECMO. Think about it, ECMO is the long-term bypass, so if you need to put someone on bypass for a few days, ECMO is your choice. This is in brief. As we said earlier, a lot of centers in Japan and Asia use the carotid cannulation as the first line of peripheral cannulation. In brief, understanding the anatomy, as you can see, the carotid triangle bounded by the anterior border of the sternocleidomastoid, the posterior border of the omohyoid, and the posterior border of the digastric muscle at the side of the neck. So your aim during the dissection is to flip or to unwind the anterior border of the sternomastoid, and hopefully you will find the carotid sheath in there. Looking at it in a cross section, as you can see, it is wedged between the posterior border of the thyroid gland, the sternomastoid, and the paravertebral muscles. The carotid sheath itself encompasses three structures, that is the common carotid, the internal jugular, and the vagus nerve. Now I need to stop here for a second. So what is this nerve on the surface of the carotid sheath? This is essentially the ansa cervicalis, three motor muscles which supply the infrahyoid muscles. And a rhetorical question in here, what happens if you inadvertently injure the ansa cervicalis? The answer is nothing. The infrahyoid muscles are meant to are auxiliary muscles of deglutition, swallowing. The primary muscles are the pharyngeal constrictors. Inadvertently injuring the ansa cervicalis will lead to paralysis of these infrahyoid muscles. However, the function is not affected because of the same pharyngeal constrictors. This explains why the reason why I'm mentioning this is to explain that that's why we can use the ansa cervicalis as a substitute or as a flap in case of recurrent laryngeal nerve injuries, because we can sacrifice it. You can take it out without losing its action. Also, it is very convenient because it gets the same neurological impulse during swallowing and phonation, because it supplies the infrahyoid muscle, and hence you can use it as a substitute to the recurrent laryngeal nerve as a surgical treatment of injury to the recurrent laryngeal nerve, which is a topic we will discuss in thoracic surgery. This is about it. regarding the cannulation sites. I hope you found this chapter useful. I'll leave you now with this MCQ question, and hopefully we'll meet in the next chapter. Thank you very much.